Hey everyone, what is going on today? My name is Corbin Cressley. I am a coach here at CrossFit Mount Juliet in Nashville, Tennessee. Wanted to just first of all say hello and thanks to Austin and the guys at Coaches Compound for having me on today. They have asked me to do a kind of orthopedic type of talk about the shoulder and the upper extremity, and so kind of following and building on their lectures so far on the upper and lower extremity. We're going to have a series of these videos that talk about some of the common injuries that typically as coaches we're going to see in the fitness industry and even in the athletic world as far as upper extremity injuries and lower extremity injuries. These are just the common ones. There's plenty of others out there. We're going to hopefully just give you a quick overview of the anatomy and some of the common reasons why these things happen. So I just wanted to say hey and introduce myself. Like I said, my name is Corbin. We've got some tags up here that you can follow on Instagram, Facebook, social media outlets. First of all, obviously, Coaches Compound #1. My own personal one's up there, CB Cressley. And then the gym that I coach at is CrossFit Mount Juliet. Give them a follow. There's always some entertaining stuff going on there, especially on Saturday mornings when we have our group workouts open to the public. We usually do some live streaming, stuff like that. Have a little fun with it. So take a follow there. A little bit about me. I am a friend of the Coaches Compound via Liberty University. That's where my undergrad training is in, and I've studied sports medicine there. I have a Bachelor's of Science in Athletic Training, and currently here in Nashville to complete my master's degree as a physician's assistant. And so in the middle of that, I'm kind of taking some time, taking a little study break here to talk a little bit about some things that I've had more experience with and really enjoy doing and enjoy treating. So hopefully y'all will get a little bit out of this. Like I said, this is purely based off of my own experience and everything like that. So if you've got some other ideas or other experiences that you'd like to share with us, please feel free, leave a comment, send us a message, whatever you need to do, and just get in contact with us and let us know how we can improve these sort of talks. So I want to, first of all, before we get started, give you a few disclaimers. First of all, like I said before, I'm a certified athletic trainer through the National Athletic Trainers Association and not currently licensed in the state of Tennessee to practice, and not currently practicing as an ATC due to a full-time master's program that's pretty rigorous in itself. Like I said, I'm a PA student here in Nashville, so I'm taking time to do that. And then once I get out, hoping to jump back into the orthopedic world and treat more of these musculoskeletal type injuries with just a little bit more training under my belt. So just wanted to throw that out there immediately. And then second of all, not sponsored by anybody. Nobody's paying me to do this. This is just a fun thing and an honor and a blessing to be able to do this for the Coaches Compound and be a part of their team. So really excited to do this. But again, nobody's paying me to be here. So and again, just like I said before, speaking from personal experience here, I'm sure there's way more expert opinions out there. I've been in the fitness industry now for about 5 years, as well as the sports medicine industry. Played sports all the way through my childhood and through high school. So I've been exposed to both the sports side and more just the traditional fitness industry side of things. And so have a decent fund of knowledge to draw upon. But again, this is all just really personal experience based. We've had plenty of experience in the personal training world, in the CrossFit world, and also the sports performance world as well. So if you, like I said, if you have any other experiences or would like to share with us, just get in contact with us, and we'd love to add your story to what we're doing here at the Coaches Compound. The next thing I want to say, before we really dive into the nuts and bolts of some of these pathologies, is when in doubt, refer. That's kind of my common catchphrase. Again, there's always somebody out there who probably knows a little bit more than you do, and it's okay to admit that. So if you're not sure, there's no need to try to be a hero and try to fix something on your own. As a coach, if an athlete comes up to you and says, hey, like my shoulder's really bothering me when I do this movement, and et cetera, and you don't have adequate training or don't feel confident in giving them some recommendations, be it for corrective exercise or some basic treatments, go ahead and just send them on to somebody, either a friend you know, a doctor, somebody else that has more training in this and can adequately address the issue. Again, this is really just speaking from my personal experience, and so these are a lot of the things I've seen, treated, been taught how to treat, things like that. So again, everybody's experience is going to be a little bit different. We just encourage you, when you're in doubt and you're not sure about what to do, refer to somebody else who has a little more experience. And another thing, like I said before in the beginning here, we're covering the most common pathologies. This does not mean this is an all-inclusive list. We're going to try to hit some of the major things that you'll see. If you've been watching the anatomy lectures so far that the Coaches Compound has put out, great lectures, really in-depth and really helpful to understand the body, just kind of get a visual on what it looks like. And how all this wonderful machinery is put together. This is another sort of one of those deals. We'll be using the Essential Anatomy app to basically just kind of illustrate and point out some of these areas. I know for me, being able to see the structures that's usually injured or basically hurt in most of these scenarios really helps you understand why it happened, what we can do to prevent it from happening, and how to make it better, or at least manageable in the time being. So that's kind of where we're coming from in these most common pathologies that you'd probably see. Pathology is a fancy word for injury. So like I said, if there's anything else, let us know, or anything else you'd like to have addressed, let us know. We can try to do a little extra segment on that. So what we'll need to do before we start is basically have a really good grasp and understanding of general ranges of motion that really the shoulder joint goes through, the scapula or the shoulder blade goes through, and then really the elbow. We'll kind of save the wrist and hand. If there's enough interest and y'all really want to see some information on the wrist and hand, we'd be happy to do that. But there's plenty to talk about in the shoulder, elbow, and kind of that scapula and thorax to cover enough time here, a couple minutes. So we're going to address those today, and we just need you to know some basic ranges of motion. So if you're not familiar with terms like adduction, abduction, flexion, extension, and what those movements look like at basically all those joints that we talked about, go ahead and review those. There's plenty of great resources out there, YouTube, even Instagram, I'm sure has some things out there that just kind of help you orientate yourself with those different movements. I'll be referring to those movements a lot in this talk, so make sure you kind of know what we're talking about when I throw out those terms. I'll do my best to make it understandable, but there may be some times where some medical jargon just sneaks out of my mouth and I don't think to correct it. So like I said, if you have any questions, feel free to leave them in the comments below. But if not, like I said, get yourself a little bit of prerequisite training. I'm hoping to put this on a level that most coaches will understand. And so just let us know if you have any questions. So thanks. Hang tight. We're going to get Essential Anatomy fired up, and we'll get right into our discussion for the day. All right, everyone. Welcome here to our demo and kind of instructional tutorial on some common injuries here in the shoulder. Just giving you all a real quick preview of the main joint we're going to hit today. We'll also go a little bit downstream here and look at some kind of common pathologies you'll see right around here at the elbow. But most of our focus, like I said, will be up on the shoulder and kind of the main area of focus. That's typically what I've personally seen in my experience being the kind of common joint of complaint. And really, most of these shoulder issues are coming from the fact that we have a very, very loose joint, if you will, a joint that's capable of really high ranges of motion that we typically call on for a decent amount of stability. And really, the body likes to either have one or the other, not both. So if a joint is very, very stable, typically it doesn't have quite as much range of motion, which is good. Usually means that the injuries are a little bit fewer in that sort of joint. But here at the shoulder, I'll actually take these muscles away so you can see. Watch out, we're going a little bit close there. I'm going to take all these muscles away just so you can see kind of how impressive this joint is without any connective tissue, without any muscles around it. Really very essentially loose. Not a whole lot of articulating surface here. Really we've got here and here. This is the glenohumeral joint. This is the glenoid fossa of the scapula, and this is obviously the humerus and the head of the humerus. This joint has been described as the golf ball kind of sitting on a golf tee, if you will. So very, very loose, unstable joint in itself without any muscles or connective tissue. But thankfully the good Lord gave us some of both to kind of help stabilize it. So first and most common pathology we're going to see is going to be those of the rotator cuff. So injuries to the rotator cuff. I've heard plenty of people call it plenty of things. I've heard it referred to as the rotator cup. That is not correct, although very close. We've also seen it plenty of other interesting names out there. We were looking at the rotator cuff. The rotator cuff is made up of 4 muscles that typically are remembered with the abbreviation SITS. So SITS, we've got our, if it'll let me click on it, our supraspinatus, which is the first S. We go to the I, which is our infraspinatus, and our T, which is our teres minor, and then our last S on the front, which is our subscapularis. These are kind of named for where they're at, save with the exception of the teres minor. This infraspinatus, the infra means below, and it's below the spine of the scapula. The supraspinatus is obviously above the spine of the scapula right here. So, and then obviously subscapularis, kind of below the scapula, if you think about it in relation to the thorax here and the ribs. So, some of the most common pathologies you see, just that you'll see with any muscle, we'll also hit these on a couple other muscles of the shoulder joint itself. It was really just a strain. Strain is, all we're looking at is basically some degree of tear in a muscle or tendon. And so you have all this musculature here. It's obviously not quite as big as we've got it blown up to be here. These are very intrinsic muscles. If I take and layer some of the muscles over top of the shoulder, you'll actually see, whoa, there we are. We've got our pectoralis major, our deltoid, and things that cover this shoulder joint here. So you're really looking at kind of more intrinsic muscles when we're talking about this rotator cuff. So it's kind of one of the reasons why it's injured. Since it's some of those, it's really just an intrinsic set of muscles. We rely on these muscles to kind of stabilize the joint. I'm going to get a pen out here so I can kind of demonstrate. Oh, cool, it's going to let me choose a color. I'm going to take kind of this yellow pen here. Maybe it'll turn out to be neon green, I guess. And basically our function here is to drew this arrow because these muscles, and most of these muscles are going to function to pull the head of this humerus into that glenoid fossa as the shoulder moves through some of its ranges of motion. Typically, these muscles are most active when we're doing abduction or taking that arm away from the body, even up overhead, or even a little bit in flexion and extension, raising our arm in front or in back of us, respectively. These muscles can really help just basically pull that humeral head in and stabilize it so that it doesn't slip out of joint on us as we move through these ranges of motion. So let me clear the pen out of the way. That's kind of our main function. You also hear you hear rotator cuff in the name, so obviously it's going to create some internal and external rotation at the shoulder, and that's going to vary depending on what position the shoulder's in and what sort of rotation we're doing, be it internal or external. Typically, you think of these muscles here are SIT muscles, supraspinatus, infraspinatus, teres minor. Those are going to help create external rotation, and then our subscapularis is going to help create internal rotation. The muscle starts here, ends here, so if I pull it along that line, obviously this shoulder joint here is going to rotate inward. So that's kind of the main functions of this rotator cuff. So let me zoom out just a little bit so we can get a better look. Like I said, most commonly you're going to see the injuries you're going to see are some tears in any of these muscles. More commonly that we see is a tear that's going to be approximately somewhere in this area here on the supraspinatus, and typically that tendon where it inserts into the bone, the humerus. This can happen from a lot of different reasons. And typically, even in some people, it can be even just sort of a degenerative thing where over time the tendon gets a little weakened just by normal everyday stresses. We've seen this, a tear of the rotator cuff in general all along here can be caused simply by almost even in people who have those degenerative changes in really almost just putting a box up on a shelf or something. They can feel kind of a tear or a little pop. And that'll be just maybe a partial tear of one of these tendons somewhere along the chain, and that can be as simple as it is. You also have pictures baseball pitchers, quarterbacks, athletes that are throwing the ball. You have even volleyball players making contact overhead or any overhead sort of throwing motion. You can have a lot of shearing force on these tendons, and they're also required to slow down that arm as it kind of comes in the follow through. So you really have a lot of pressure put on, especially from an athletic standpoint, these tendons. So they can obviously just either do a minor tear, which would be something which we'd call like a grade 1, which may be only like what we'd here call a partial thickness tear, or you could have a full thickness tear, which would be more closely related to a grade 3, which is going to be more all the way across right there. Typically, you see this, I mentioned before, you see this supraspinatus tendon injured, typically because it's got less room to pass. Let me move this just a little so you can see it, than these other tendons do. And the reason it being because it has, this is the scapula and the acromion process, that hook that comes out. It's called a acromion process, and that is going to limit the amount of basically space that this supraspinatus muscle and tendon have to run underneath that acromion and onto the shoulder. So when I take this shoulder and this arm and I go through abduction, right? So I'm going up in this direction here, taking my head, or my hand over my head, kind of from a lateral aspect. That is going to create a little bit of pinching right in that area right there. So a lot of times, just even people who go overhead often, maybe you may not be an MLB pitcher, but you may be reaching overhead a lot, something like that. You can even see this in swimmers and athletes who are just going through abduction, flexion, or a combination of some of those movements that get some sort of pathology or inflammation or something right there. So again, this is all some of those common pathologies that you might see. I know I'm kind of jumping around a little bit on those, really just kind of listing them off as they come to my head, but you can think typically anything overhead. That might be a lifting, so in the CrossFit world, maybe like a snatch, hanging from a bar to do some gymnastics work, be it pull-ups, toes to bar, muscle-ups, anything like that. A lot of different things, even some pressing motions, like in a shoulder press, any sort of jerk motion, so a push jerk or a split jerk, and even in the bench press, in the more non-CrossFit circles, you'll see this tendon get some degenerative wear and tear, and eventually get some sort of tear along the tendon. These don't always have to be tears either. A lot of times we can just get a general inflammation of the tendon or the muscle itself, and that's typically called rotator cuff tendonitis. The itis suffix there tells us that we've got some sort of irritation or inflammation going on in that tendon itself. So those are some of the more common pathologies you'll see at the rotator cuff. And really, honestly, a lot of times we just see people that these muscles aren't terribly active, or other muscles that complement these muscles and surround the muscles don't work well, and so we just have limited range of motion. So maybe in external rotation or internal rotation, you see some deficits, and that can predispose us to injuries, or just kind of limit our functioning overall. So those are all just some common things. Again, just to review those, you could have any sort of partial or full thickness tear of one of these tendons or muscles. The rotator cuff muscles. You could have some generalized inflammation of these tendons or muscles, which would be tendonitis, rotator cuff tendonitis, and you could even have just some limited range of motion. So a internal or external rotation deficit that is going to predispose us more to injuries of the shoulder, or even of some of the musculature that we're going to talk about here in a second, that runs from the scapula to the ribs and to the thorax itself. So again, that's a very brief overview of the rotator cuff. Just want to let y'all see this and kind of see what muscles we're talking about when we talk about the rotator cuff itself. Real quickly, just for the coaching piece out here, when you have an athlete that is having trouble with overhead motion, or is describing some pain in a couple different areas, let me pull the skin up just so we can kind of see what it would look like, just to give you a frame of reference. Now, that supraspinatus tendon that you pictured running up here, a lot of times we're actually going to get some pain in this general area. An athlete's going to come and say, man, coach, my shoulder's just really hurting right here. Anytime I either go overhead or try to hang from a bar, like pull my arm out like this, meaning external rotation, they'll say they get some pain in this generalized area. It's actually typically not up in the muscle belly itself. It's more just below where that tendon comes and inserts itself onto the humerus. So that could be a common area of pain. But you can also see areas of pain kind of along this back half of the shoulder here. That may be more of an infraspinatus or teres minor sort of pathology, and it could also be some tendonitis from our muscles that also run. This is actually our triceps right here, triceps brachii, and you see that tendon runs up there into the shoulder complex. We could also have, if I add some muscle to this, we have our latissimus dorsi that kind of runs in this area. There's also another muscle called the teres major that could be involved. So there's plenty of things that are going on specifically, but really it's going to limit the athlete in either external or internal rotation, something like that. So they're usually going to have, like I said, pain about the shoulder joint itself. Typically, though, not in the shoulder joint. Sometimes you can ask an athlete, now, is your pain does it feel like it's kind of on the skin or what we'll call superficial, or does it feel like it's like deep inside the joint? That's a helpful question, but it may not be an all-encompassing question. As far as actually figuring out what is going on with this athlete. But it's a good place to start, and like I said, those are some of the typical areas of pain that you'll see athletes develop. So just kind of give you a little heads up as far as that goes. Nobody, you'll find out in the coaching world and in the health and fitness industry, sports industry, injuries do not look alike. They are classic, and a lot of times function a lot alike, but everybody's an individual, and so it's tough to say this is what this will look like for everyone. So just keep that in mind as you look at the rotator cuff and at the shoulder itself. Again, the rotator cuff is probably our most commonly injured structure there in the shoulder, so just wanted to cover that real quick. Next, we're going to move on to the glenohumeral labrum. It's a really fancy term to say. Let me put some connective tissue up here. To say basically the cup that the humerus sits in. So let me pull these away, get this a little more on center. Not that much on center. Hold on. Trackpad's a little touchy today. Okay, so this is our glenoid labrum. I'll give you all a rotated view of that. So let me see if I can isolate it here. Actually, let me take the capsule away. We've got a bunch of ligaments here. Hold on, got to remove those. What we're going to talk about here is the glenoid labrum. And you can see how all these ligaments actually encompass. I'm actually going to pull this one out of the way as well. You can see all these ligaments and how the muscles really encompass. That's a Bursa Sac that helps the joint move well, cushions it a little bit. You can see how all of these muscles and ligaments help provide stability to the joint. And here's one more piece on the rotator cuff, forgot to mention earlier. We also have a Bursa Sac in here. And so generalized inflammation could be from the tendon, the supraspinatus itself, or it could also be from this Bursa Sac. Typically, these Bursa Sacs are flat. Like I said, just help provide some lubrication and cushioning for the joint. But if any sort of inflammation gets about the shoulder, it can find its way into a Bursa Sac and essentially blow this up, sort of what might be like a balloon. Any sort of inflammation here may not cause us pain initially, but if we go through some range of motion, be it abduction or something overhead with this supraspinatus, now all of a sudden we don't have a whole lot of room for that tendon to move anyway, and then we've blown this sucker up like a balloon, and all of a sudden we really have no room at all, and so that's going to create some pain moving overhead as well. But moving on to the glenoid labrum, this is the glenoid cavity like I talked about before. I can get this labrum to, get this labrum, there we go. So the labrum is going to basically surround that glenoid cavity, and along with the ligaments help provide kind of a deeper articular surface for the head of the humerus to sit in. A lot of times we can have some pain with this if, this is kind of cool to see, this is actually the head of our biceps. A tendon of the biceps that you see actually comes in and hooks into the labrum itself. And so we can have any sort of inflammatory process along here, some sort of tendonitis along here that creates some more anterior shoulder pain. And we can also have some force that gets put on the labrum and actually can cause this to kind of pull off of its attachment site. And that'll also create us some pain as well. But what's really cool is this is just a kind of evidence of how amazing the human body is put together. Let me see if I can move this down. Like, that's your bicep. We think of the bicep as the muscle that helps your arms look really good and helps you move your elbow. But in reality, we all know as coaches as well that this is going to help create some flexion at the shoulder or forward motion of the shoulder. So if I take a pen and draw this, moving the arm moving that way. So it's really cool to think that the biceps also has that function as well. So with that, with shoulder flexion, typically you might be able to have some sort of tear along this biceps tendon, or like I said, more commonly some inflammation here as it passes through or passes around the humerus. And also, like I said, can have this labrum kind of pull away. We can get any sort of tear in this labrum that'll create some pain. And the biggest way to differentiate this is, like I said, the way the athlete presents the pain to you as the coach. So the athlete may come to you and say, "Hey, coach, I've got some pain, and it kind of hurts in certain ranges of motion, but doesn't hurt a whole lot when I move it." Or, I just feel like there's some pain deep in the shoulder and it'll catch. Even though may not be terribly common, they may typically refer to the pain as more deep in the shoulder, and so that's something that you can be on the lookout for. Now, the glenoid labrum, like I said, is just connective tissue, and so in order to kind of differentiate this pain versus a rotator cuff pain, it's really helpful to ask the athlete if it hurts when the athlete themselves move it with their own muscular power. So if they're moving their arm with their rotator cuff muscles and the deltoid and pecs and things like that, if they've got pain with their what we call active range of motion, or when the athlete moves it, typically we're looking more than likely more at a muscular problem, so a tendonitis, strain, something along those lines. Whereas if the athlete says, "I don't really hurt it when I move it," but we take and move the athlete through some ranges of motion passively, so we take their arm and move them into flexion, move them into extension, move them into abduction, and even some horizontal adduction. The athlete may report some pain there, but not when they're actively moving the arm. And so that may be a little differentiating factor between, is this just a labrum issue or more of a connective tissue issue? Like I said before, with some of this capsule here and these ligaments, and more specifically the glenoid labrum, or we looking at some sort of muscular issue around the rotator cuff, which is more indicated by pain on active range of motion. So those are some of the big issues with the shoulder. Those are the things that have kind of popped in my mind as I've sat here and looked at this shoulder itself. If there's other things or other things you've been exposed to or seen, or maybe even have questions on, post them in the comments. I'll do my best to reply to these and kind of answer some of those. If obviously the best answer is, if you don't know, look it up. And so I'll do my best to look some of those things up. Again, this is all really just off of rote memory and what I've seen and experienced. And there may be a few things left out. I hope not. But like I said, if you've got more questions or feel like there's something that needs to be corrected, please, by all means, let us know, and we'll be sure to fix that up. So I want to move on now to some of just the more general strains that we may see around the shoulder joint itself. Let me get readjusted here. I'm going to take away the connective tissue. And let's see if I can. It's not what I want. Reset this bad boy. All right, so got the shoulder back. If you are of the CrossFit following and work in that arena, you have more than likely heard about some of the quote-unquote pec tears at regionals. And we will not get into the philosophy of why or why not that may be happening and why that happened, well, yada, yada, yada. There's plenty of theories out there, and a couple I think that really hit the nail on the head, but ultimately it happened. So what are we going to do in response to that? Here's what we're looking at. I think really some of the more common issues and strains you'll see is pectoralis major, then latissimus dorsi, or lats, and even maybe some in the traps as well. Everybody all those guys love those big traps, right? Make your shoulders look huge. But in reality, a lot of times we get some tightness, or more than, maybe even some strains up in here. A lot of times you'll even see what we call trigger points or adhesions in the muscle and the fascia itself. Those can happen a lot through this area here, up into the traps, and especially into like this area of the pec kind of this triangle of the pectoralis major here. And so really, like I said, just like with the rotator cuff, a lot of times the athlete will complain of some pain on active range of motion. There may be some sort of physical deformity. So if we took and try to isolate this pec major here, so we see how it fades into and attaches to the shaft of the humerus. There may be some sort of full thickness or nearly full thickness tear here, and so what may happen, an athlete may present with kind of a deformity, and I'll pull the skin on so you can see this, may see some deformity through the chest, and through basically kind of like this anterior axillary area or the armpit area, and that would obviously be pretty concerning. That's not something you're not going to try to fix yourself as a coach. You're going to refer them to an orthopedic surgeon or somebody with more experience in orthopedics to have that looked at, because that's obviously any sort of deformity that we can see with our eyes in the chest area. It's probably going to be some sort of more severe pec tear that the athlete's going to need a little bit more help with. So let me take the skin away again so we can look at the pec. That is again, a pretty severe presentation, any of that obvious deformity. But you can have some pain here in the anterior shoulder that indicates some sort of pec strain. And y'all will need to recall what the pecs do. They're going to basically do our pressing motions or horizontal adduction. So the muscle is going to pull, let me pull the pin out, in that direction. So it can do anything that if we took and shortened this area, or took that area and anchored this area here, that was not very straight, and we take and draw kind of tension lines or action lines this way, that's what the pec's going to do. So it can create horizontal adduction, can create a kind of flexion sort of motion as well. So those are all things that our pec can be involved in. The lats are kind of the opposite. Let me get it to a better view here. They're going to kind of adduct our arm. So originate down along this line and insert. Let me select the lat and fade the other thing so you can see where it kind of goes into. I love this little feature because you can see how it actually hooks around and attaches to the front of the humerus. So what we're going to have here is a line of action right there. I'll draw some more action lines just so you see that. Again, originates down here, inserts up here, and so the line of pull is going to be there. You use it on pull-ups. We use it to adduct the arm, adduct the arm. So any pain in this general area, you can even, less commonly, but can even have some pain along its origin point. But like I said, typically you're going to see that more at the shoulder itself. So that could be some sort of latissimus dorsi strain. Probably going to see it when an athlete's doing some sort of pulling action, such as a pull-up, horizontal pull, anything in that realm could injure our latissimus dorsi there. Like I said, those are two major ones that we can see. Talked about a little bit of it, like I mentioned the word adhesion or trigger points up in the shoulder area, the thoracic area itself, and we're going to attack that area a little bit more now. Let me remove some of these muscles. Actually, add those, need those. So here, the major muscles in question now that we'll typically see some of these adhesions along are the traps, the trapezius, like I just removed, which are right there, our rhomboids, rhomboid major, rhomboid minor, and the serratus posterior superior. I'm probably not going to cover that one quite as much today, or our levator scapulae. So I'm going to draw a few lines of action here so you can kind of understand where these muscles work and how they work. So these are kind of all the actions that these three muscles, the rhomboids and the levator scapulae, are going to do. We're going to pull the shoulder blade back, kind of back and up, and then up, like a shrug sort of motion. So a lot of times, you do a lot of pulling off the floor. So if we're looking at our cleans or any sort of Olympic lift or deadlifts, and a lot of things that we use in the CrossFit world, but also that you'd see in the athletic world, in a lot of strength programs, and you'll see some tightness and pain up in this shoulder area. A lot of times you can actually palpate or physically feel those knots, what's typically called quote-unquote knots in the shoulder, or trigger points. And those are all pretty common in athletes who are pulling off the ground a lot in their weight training programs. And so that's just something to be aware of as a coach. And a lot of myofascial release techniques that we'll hopefully do some videos on a little bit later, can really help alleviate those and aren't as big of an issue. Really all you're going to see there is just maybe a little bit of decreased power output from these muscles themselves, but there's still things to address. If we let trigger points and adhesions go long enough in these muscles, or even in a lat like this area here, drew that arrow in the wrong direction. But if we have some adhesions in the lats, in these muscles, even in the pec, we can predispose the muscle to injury and further tearing or strains. So obviously some things we need to correct, but obviously all are very correctable things, these adhesions and trigger points. So just some things to be aware of as far as this area itself. So one more thing I'd like to cover. We're going to get out of the shoulder area just a little bit. Like I said, very brief overview, and you're probably sitting there thinking, that was not brief at all. You just talked for like 20 minutes on the shoulder. Yes, I could probably talk for at least 2 hours on the shoulder, but we're going to keep it short and sweet and simple. Most common things, just to review again for us, the rotator cuff, strains or tendonitis. We could get some biceps tendonitis or some sort of labral tearing, and then we could also have some strains of those pectoralis major, latissimus dorsi, and then some trigger points in the rhomboids, levator scapulae, and even in the trapezius, lats, and pecs as well. So those are all, like I said, just some really common things that I've seen as a coach in the CrossFit world and in kind of the general fitness industry. Again, if the athlete, most of those muscular issues, if the athlete has pain on active range of motion, that's going to point you more towards a muscular issue, whereas a pain on passive range of motion may point you to an issue more of the connective tissue at the shoulder itself. And again, if you're not comfortable either prescribing a little bit of maybe mobilization techniques or things like that for corrective exercise for these muscles, if you're not comfortable with that, don't do it. Go ahead and refer it along to somebody, an orthopedic surgeon or an orthopedic mid-level provider, something like that are a little bit more versed in these things, and that'll give you a little bit more confidence knowing that your athlete is getting the best care possible as well. Like I said, it's important to know the things you know, but also important to know the things you don't know, and both of those things will make you a better coach and make you more reputable to your clients and athletes. So I'm going to move on now, taking a break from the shoulder to finish up with a little bit of elbow issue, and this actually won't take very long. Because I'm really just going to hit one specific area of this elbow. So, just going to need to zoom out just a little bit so we can see the wrist too. Excuse me. So, what we're looking at here are what is known as the extensors of the forearm. So, if you can see these muscles, 1, 2, 3. This guy does not want to rotate for me today. There we go. So we have 1, the brachioradialis. 2 is the extensor carpi radialis longus. These names are not terribly important, so I won't browbeat you with them. Muscle number 3 is extensor digitorum, and then extensor carpi ulnaris. These are all nice thing I show you these names because most of them have extensor in them, except for the brachioradialis. The brachioradialis has a little bit more function even kind of down at the thumb, so we won't hit on that a ton. But what we're concerned with is really just like we talked about in the rotator cuff, some tendonitis right in here. Typically the athlete will complain with pain on extension of the wrist, so this motion of the wrist right here. This can be gripping weights, just general extension against resistance of the wrist. Those are all things the athlete will complain of when they've got some sort of epicondylitis. And it's weird because this medial epicondylitis you don't think as being a wrist issue, and it's really not, but that's where the injury stems from. And so the force that's going on, that's being put on the wrist by these muscles, are what's going to create some inflammation of these tendons all along here. Let me zoom in a little bit on that so you can see. Maybe not. Gotta get out of my pen mode here. There we go. So all this group of tendons right in through here are what can be inflamed or irritated, created a little bit of micro injury created by inflammation at that elbow. So if athlete's complaining of pain on that lateral aspect of the elbow, we'll put some skin up so you can kind of see this right here. A lot of times they'll say, man, it gets worse after I am done with activity for the day or after I'm done working out. That's kind of a common presentation. And just kind of general achiness in this area here. I've seen athletes that have been severe enough to be kind of even limited in activity just by some inflammation along these tendons. And again, just like I said, any sort of inflammation or adhesion, trigger point, whatever you want to call it, that happens along a muscle can predispose our muscles to injury and strains. So we need to be able to recognize these things and take care of them. Something as simple as just icing that area and providing it with some rest may be enough to knock it out. But again, if you're not really sure and confident on some common treatments of these issues, then I would just go ahead and send it along to somebody who knows a little bit better. So we're going to hit the last part, which is medial epicondylitis, what may be known as golfer's elbow. We just covered the lateral side, which is lateral epicondylitis or tennis elbow. And the epicondyle here is just really this the piece of the humerus that's along this medial side, or this lateral side. It's kind of that curve outward of the bone, the widening of the bone there as it comes down to the elbow joint. So we can have, if the lateral side was our extensors, this side is going to be our flexors, wrist flexors, or even some pronators of the hand. But here's our flexor carpi ulnaris, flexor carpi radialis, and palmaris longus. And the extensor flexor digitorum is deep to these muscles here. But so these muscles, again, same sort of presentation as that lateral epicondylitis, pain with wrist flexion. And typically, if you move the athlete through wrist flexion, through passive range of motion, they're probably not going to be have to experience too much pain with that. But like I said, on active range of motion, it may limit their grip strength and so any sort of wrist activity at the wrist that requires at least a little bit of strength out of the hand to complete some range of motion. So that's kind of our common area there. Again, you're going to see the same sort of deal. It's kind of a dull ache or even maybe a sharp pain right along this area of the elbow, kind of inside the elbow. Pull some skin back up for y'all to see that. Can even be radiating, see it probably more commonly with medial epicondylitis, can be radiating kind of down in here to the forearm as well. But irregardless, it'll be on one of those two sides of the elbow. And again, it's just maybe a simple matter of what we call RICE or rest, ice, compression, elevation, that sort of thing to help limit some swelling. But more commonly, the ice and rest will be helpful. But again, if those are sorts of things that don't help it out, and if doing some myofascial release of this muscle down here doesn't help us, maybe time to send it along and just get a second opinion on it. So that is kind of the end of where I'd like to cover for y'all today. As far as just some of these really common pathologies of the shoulder, and really the upper extremity in general. Obviously, there's plenty more, but just kind of the most common that I've seen in the fitness industry here recently. And so just wanted to give you all just a little bit of visual on these muscles and hopefully a little bit more education on how those injuries work. Again, if you're not confident in diagnosing or recognizing, treating these injuries, don't give it a shot. That's okay. It's okay to tell your athlete, hey, I think this may be going on, but I'm not sure, and I want to give you the best treatment and care and advice possible. So they won't be offended if you get them seen by somebody more knowledgeable. So again, it's all about knowing what you know and also knowing what you don't know. So treat your athletes as best you can and use this info to help and to maybe kind of help guide your discussions with athletes and explanations to athletes as far as how these injuries work and what are some common things to look for. But again, this is a very just brief general overview of of some common injuries to the shoulder and arm itself. Thank you all so much for listening and following along, watching this. Like I said, give us a follow on the social media outlets. Stay tuned. We've got more coming in the realm of injuries, common injuries. We're going to hit the lower leg here soon, and then also hopefully talk about some things that we can do to help limit these injuries and hopefully stop them even before they start. So thank you all again for watching. Stay tuned, and we will catch you all next time.